Welcome everybody to the talk again on vaccines and variants. This is an updated talk with new information, new literature. I'm going to try to cover as many points as I can to try to help everybody work through this. So as you know, whenever I speak, especially I have some colleagues on the phone, online, I have to always make sure that I give my disclosures of what I said, what I didn't say, so that nobody's surprised that they weren't given proper information. Also acknowledgements for many people. I actually owe another little acknowledgement in here to one of my folks, Jerry Rotter, who works with me on some of the stuff. And Jerry, I want to thank you for some of your input. Always a thank you to my boys. This is three of them who I'm always glad to work for. The books, you've seen this before, so I'm going to skip right through these. These are all the books I've written that you've probably seen before. These are the articles that I've had published in the peer-reviewed literature on coronavirus. Again, ones that you may have seen in the past that are still applicable, and ones that are available online to people if they want to read through them. And again, it has some helpful information about some of the principles we're going to talk about today. Okay, rest stop. And then what I want to do is just review with you. I'm going to do a brief history. We're going to go through some testing, and then we're going to talk about the current experience, which is where I think most people want. On the history, people still ask me all the time, where did this come from? What is this like? Or those kinds of questions. So, you know, I've gone through and just gently summarized some of the history of epidemics versus a pandemic and past ones that you may have heard about. And these can be helpful because they help inform what was done in the past, what might be done in the future, what might be helpful to draw information from, right? And this particular one, a lot of the stuff that came out in the history that people always ask me about is the bats versus not the bats, the animal host versus not host. The best science we have right now, and by the way, I don't think we'll ever get perfect science on this because of, you know, where this started and everything, but the best science is this was probably from the gain of function research that the US actually funded, was being carried out by the colleagues in Wuhan. And there's just a lot of question marks about, you know, what would seem to be making more sense is that this probably was, you know, some kind of virus circulating for a while, kind of more human to human, maybe from a leak, maybe some other process there, and then it kind of expanded. And there's certainly timelines that look at all this stuff, which you can all look at and review and such. But again, I'm not, you know, a big, you know, fan of always just looking back, but I do want to be honest because people always ask me about this, about what went first, who went first, where was this? And again, probably the best science, if you can call it that, without getting, you know, good help from all the different governments of, you know, full explanation, is probably the gain of function research that, you know, Dr. Fauci was funding and probably got a little bit away from things. That would probably be it, but it's so hard to know without having, you know, full disclosures everywhere and really clear communications. Okay, a little rest stop with my family. Now, on to things I think are more germane, which is, first of all, the immunology. Okay, so I want to remind you of this. This is very important for everything that we're going to talk about. That is because there are two parts to the immune system, right? What happens is you have these things called antigens, which is the virus. It comes in contact with a macrophage. The macrophage then produces and stimulates T cells, right? It interacts with these T cells. And then what it does is it starts going through a cascade of more T cells and going through more of the antibodies and the memory cells. This is critical. You have to remind yourself of this every time the subject comes up, because this is not talked about. But this is how we've always functioned. And this is not big or sexy or interesting to people that are only talking about antibodies, to people that are only talking about immunizations and antibody responses. But the fact doesn't change that this second system, the cellular system, which is the T cells, provides a lot of protection, not just for antibody production from the B cells, but because of its own impacts. Please keep that in mind. So when you're looking at blood tests, people say, I want to check my blood, right? You want to look at the antibodies. So here's the data. You get your first antibodies, called the IgMs, in 4 to 6 days. Peaks around 12 and starts declining after about 35 days. The IgG, that's the long-term one. That's the one that we talk more about because it's more persistent, lasts in the system longer, right? So those start coming out around 10 to 18 days and last much longer. Now, we already know from other related infections, SARS and MERS, that those IgGs lasted for many years, right? Now, when they're talking about now, the drop-off. So let's just look at it. Here's a different way of looking at it. This is with a graph. Okay, so stay with me. Stay with me. Look at the graph here. So you get your exposure to the virus. You start having responses on what these are the PCR tests, right? And notice that right now, you're really just getting that evidence of the virus replicating, and the detection becomes less likely. But when you first get your symptoms, look how much is up there, right? Look how much viral particles are there. That's why it's so important to remind yourself. When people say, well, they should do testing, right? Well, you can do testing and you might not see the actual virus because it's down in this phase where it can transmit, but there's no symptoms. People aren't getting tested. And so people are going to functions and interacting with folks. And that's why you always get these calls and you say, oh my God, I was with this person yesterday. They felt fine. And today they have symptoms. Were you exposed? Absolutely. Right. And that's one of the reasons why on a lot of times when you ask me about testing, especially for the PCR testing, I'm equivocal because it's really dependent on where we are on what to do. Also, notice, look at this. Look at how some of these PCR tests remain positive for weeks, right? That's why when you all say to me, well, look, I'm feeling better. Should I test to see if it's gone? The general answer, no. Because if you test somebody to see if they still have the antigen, you can pick up viral particles. But those are not infectious. You're not going to give it to anyone. So testing often has very limited benefit in that regard. Now, the second part, the antibodies. So look, here we go. So you got the infection, and then in that second week, those antibodies start rising up. And then we talk about how long do they last. So we already talked about the IgM, that goes away a little quicker, but the IgG goes out for a long time, right? And when they start talking about, well, you said the antibodies go out for a long time, but I say that I see all this stuff in the newspaper about this stuff dropping off. Look, we're going to talk about that. I'm going to show you the graphs. It does decline, but not to zero, right? I want to show you something else. Very important, very important. Look at this very carefully, right? If you look at this slide, what you'll see is that if you test people carefully, even if they have mild disease, 100% will have T cell response, 100% will have IgG response, okay? That's just how it is. That's what the way the system works. So when you're saying, well, they didn't have it very bad, maybe they're more risk, not true. It's very definitive that anybody's had this does have response. What's more, I reminded you of this before because I think it's very important what's going on right now with variants, right? What's going on right now with the variants is that we have data from before COVID-19 ever existed. This is blood from many years ago. That when you tested them, they show antibodies. You're saying, how's that possible? Well, remember in some of my earlier lectures, I told you that there's been coronavirus around forever. And there were 4 main variants, which always caused little colds, but nothing that serious. By the way, very similar now to what we're seeing with the new variant, Omicron. So that is why you have people that say, well, I got exposed, but I didn't get that sick. Well, they probably had antibodies from natural infection long before they got a booster, long before they got the primary series, and they're protected, right? Which comes up again when people start asking me about boosters, because there's a tension there between a natural infection, which I know gives you a robust response, and the vaccines, which are very helpful, but more helpful when it's a serious variant, less helpful when it's not serious. Okay, now another way to look at this. Look. These are the cellular response. And look, as time goes on, how they diminish, but they never go away. By the way, the influenza, the famous flu epidemic of 1918, they were able to sample some people that were in their 90s, and they showed that they still had memory cells from that specific flu strain 80 years later, right? It tells you how long this stuff lasts. And when you look at the antibodies here, they do go up, they do go down, but they don't go completely away, right? I'm going to show it to you again, right? This, you're going to say, well, Mark, this is getting a little bit crazy for me to look at. What I'm trying to show you is there is study after study after study after study that shows that when you have this virus, when you have this infection, these antibodies last a long time. Further, when you take the immunization, these antibodies last a long time. So when everybody is screaming about these antibody levels, there are multiple issues to keep in mind. First of all, antibodies will be lower in asymptomatic people, and they may drop quickly. But even if you're reinfected, if you had the natural illness, you are virtually guaranteed of less illness, right? The durability is now verified for at least 18 months. So you're going to say, well, wait. You know, we had this, and then they said within a year, we got to do boosters and stuff. Look, we're going to go through that data, but I want you to keep in mind why that data needs to be interpreted very carefully. More so, not all antibodies fight the infection. This is going to be an important concept. You may not have heard this before, but it's true. It's always been true. It will always be true. Understand the following. When a virus gets a response from our immune systems, when you give vaccines, the body responds by producing antibodies. Well, not every antibody attacks the exact same way. These are a range of antibodies. And what happens is some of those antibodies will attack the virus in different locations, what they call the loci, what they call the parts of some of the proteins. In particular, everybody talks about the spike protein. Well, it turns out that some of those antibodies, when they go and attack a part of the spike protein, it actually causes the protein to alter in such a way that when that protein alters, it can be more likely to cause an infection. At 6 to 8 months, you will have about 25% of neutralizing antibodies. But the literature says you only need 3%. So everybody says, oh, the drop off. Yes, it drops off. But to prevent the things we care about, you only need about 3% of the antibodies left, right? 20% of antibodies still give you at least 50% protection, right? And this is just from getting some illness, right? We're not talking about the bad stuff. We're just talking about illness. These antibodies work, and they work at very low levels because you also have the cellular system, right? Now, the lab methods. You'll start hearing these things about efficacy. The problem is when everybody says, oh, I want to check my antibody levels, I got news for you. There's no good data that when you look at these levels, that you can compare them between labs, that you can compare them over time, or that they will dictate that if you see a large titer, that it definitely means that you have efficacy, because how that's defined in the labs varies, right? They are predictive of immune protection. There's no question about it, right? There's no question that antibodies help. That's not the issue. The issue is how much do you need and how much vaccination do you need, right? And remember, at least 90% of people will develop good antibodies after a natural infection. It's the rare person that doesn't get a nice broader way from that natural infections, okay? Furthermore, if you have a natural infection, the memory B cells will produce antibodies against new variants. The systems that we have are geared that once they've seen a real infection, they adapt their antibodies into the future. So you have to understand why somebody getting the real infection can be highly beneficial. I'm not saying I want anybody to get sick. I'm not saying I want anybody to die. I am saying that you have to understand that in particular, when there's a mild variant, it is probably in your overall best health interests that if you got that mild variant infection, it would help protect you more. The FDA clearly states antibody tests do not indicate the level of immunity or protection. There's no clear titer level, and B cells dominate anyways, which is what I'm telling you. As a matter of fact, look at this, look. This is a new test that's come out that looks to try to assay your T cells. And the idea there is to say, look, we can show you by looking at your cells that you're going to have a better immune response. And you're going to know what's possible with this testing, right? That gives you an idea of what has not been emphasized, as opposed to all the vaccinations, boosters, and antibodies, right? It is very important because it's very pervasive in helping protect us, okay? All right, rest stop, okay? So here we go. We've talked about the immunology. Now what I'm going to do is talk about some of the vaccines, okay? Stay with me. I know it gets a little complicated, trying to make it as clear as possible, right? So you may remember this. This is the different types of vaccines, right? And we've seen these in different types of diseases. Clear? And obviously the ones that we're talking most about, the new guy on the block, the mRNAs, very effective, very helpful, okay? And when you look at the vaccines in development, these are some of the different ones you may have heard about. And obviously the big ones that we talk about, the Moderna product, right? The Pfizer product, those are the two biggest ones, certainly in our country, and have grown to be very heavily used, okay? When you look at these vaccines, they have now become approved as opposed to EUA, and they talk about the different types of reactions that you can get. So this has been well looked at, okay? So what are their efficacy and safety? First, I want you to remember, very, very important, a vaccine will prevent disease, not infection, or asymptomatic viral shedding. So that's an important concept to always keep in mind. You want to know what is these vaccines doing, and what they're doing is they're preventing the bad stuff, right? They're not going to stop infection. They're not going to stop spread. Folks, this is going to be with us forever. Just like the flu has been with us forever. This is, although people don't use the term well, this is endemic, which means it's around. It's always going to be around in some form or another because it's always been around. It was just milder forms before this change, right? So if you have these around, how do you know, are they going to cause trouble? What's the risk, right? So there are 4 systems in the United States that we use for looking at trouble. Be Safe, VAERS, CISA, and VSD, okay? And let's take a look at each of those. Just so you've heard it once, you know what they do, right? So VSafe, this is with the CDC, and they have a mechanism where people can be volunteers on vaccines to check in with the CDC on a little texting, and the CDC collects data about the vaccines, the boosters, and it takes people that are willing to kind of spend the time doing that. If you ever want to do that, they'd be happy to have you do that, right? Next, the next one is the VAERS. Okay, so this is co-managed by the two of them, right? And what the VAERS does is it has a mechanism where it takes everybody that sends in any report anywhere and puts it all under one roof and just starts collating. So you could imagine that the strengths versus limitations, the strengths, it's national data. It rapidly detects signals because you're getting so much poured in there. So what could be poured in there, though, could be wrong. People could say, oh, I had a reaction. That's got to be from the vaccine, but it may not be. So the good news is it lists a ton of stuff. The bad news is it takes time to go through and look at that data and decide, is it real or is it not, right? CISA, the third one. So there are some clinical research centers with vaccine experts at different facilities, and they are geared towards receiving reports from doctors, from health systems, from the government to analyze, and they look at different reports of difficulties. And they can be helpful because they really have a lot of consultants working together to try to round that up. Last one, number 4, then we're done with the reporting systems. VSD, the Vaccine Safety Data Link. So this is, again, health systems. So there's 9 integrated healthcare systems looking at 12 million people and trying to decide what's going on with them. And it's very good. Got the computers and the links and all that stuff, right? So what happens when you do that? Well, let's take a look. Klein and JAMA looked at 10 million on this and found no data for any increased risk of any serious effective vaccine. Zoo looked at 11 million people and said, helped with the deaths, not just COVID. You say, hey, that all sounds great. Yet we know that there are side effects. And these are some of the more worrisome ones. Guillain-Barré, clotting, a severe skin reaction, anaphylaxis, myocarditis, which is inflammation of the heart. And these things happen. So when people start saying to you, well, we looked at all the safety signals, it looks fine. Look, you got to be very careful, right? One of the trade-offs of what was otherwise an incredible achievement with Operation Warp Speed and with the mRNAs is you got vaccines to the population in an incredible time with incredible efficacy. No question about it. It's fantastic, right? But there's going to be times where some of these little things take a while to surface, right? Let's look at this. In the Janssen product, right, they had 54 cases of clotting, right? So they said that females were more common, right? The women tend to be younger. And they had a more worrisome one, which was central venous sinus thrombosis, which is a clot up in the head, okay? Next, who was at risk for those troubles? Well, these are the risk factors. So now we know that if somebody's obese, has hypertension, diabetes, is using estrogen therapy, has had clots in the past, okay, then they may be one of the risk groups. But notice, look. 39%, 21 of these people had none of those risk factors. So it's got to be the vaccine plus some of those other things that we have to worry about. When you look at those clotting things, this is through December, the most recent data I could get, right? What they look at is that you're going to have trouble in about half a person per million dosages, right? And so you have to know about that. But I want you to look at something. This is very important. Look. Please, please, please look at this, right? Who are the people that had the greatest risk in this group? Look at this. The females in the younger age groups. Okay? The females in the younger age groups had the greatest risk from vaccination. But that's not the group that has the biggest risk from natural infection. So now you start to see why I have certain opinions about whether or not I think it's a good idea to get a booster. I'm not talking about the primary series, but the booster. You can also see why these things work great. I'd rather you have a vaccine than not. But if somebody had never taken the primary series, I'd say probably get an mRNA. Now I'm going to show you the data slightly differently. It's a little confusing, but I think it highlights a point. So stay with me on this. Here we go. On the left side here is all the people that you're benefiting based on age group. On the right side here is all the bad stuff, the clotting, the Guillain-Barré, the myocarditis in these different groups. And they're small numbers, aren't they? Relative to how many people you're helping, correct? Yes. And this is true in females, and this is true in males. But what I want you to know is a couple things. One, this data is most applicable to people from more serious variants. When you start having milder variants like an Omicron, then the amount of people that you're really helping starts to drop. But the risks of the vaccinations, and in particular the booster, go up. And we already saw that some of the most common areas of trouble were in the young age group. But these are the people that are helped the least by getting a booster, right? We know that with the mRNAs, you also get myocarditis, right? We know about some of these other troubles. So that's why I get very careful about what to do with boosters. I'm not talking about the primary series. That is a useful discussion. It is something we could talk about, but I'm really starting to focus now on those boosters, right? Okay, next. I want you to look at this, the kids, right? So this is in the VSAFE program, about 7 million dosage administered. Breakdown types of kids, right? Male, female, about equal. Here we go. You look at those dosage administered, and then you start seeing the reports of side effects. And you can see by age, right? So you can see that in some of these young kids, there are reports of side effects. Now, what are those reports? Okay, let's take a look, okay? So you have fever, vomiting, chest pain, some electrical or laboratory changes, but all of a sudden you've got some intensive care attention, you've got seizure, people are starting to have more blood testing done, which means that usually there's more serious stuff. What I care about a lot is the verified reports of myocarditis, which is the inflamed heart, and there were 2 reported deaths in the review. Now, hold on a minute. Hold on. Now you're telling me that in kids age 5 to 11 who have overwhelming data that get very little illness, if at all, from coronavirus, that I'm having equal, if not greater risk from the vaccine compared to natural infection. Now, look. You got to understand this very carefully. I'm not saying that they shouldn't get immunized. There could be very good reasons, like breaking down the transmission in a community. So not everybody is sick at once. Well, that certainly helps the hospitals if they're really having a severe outbreak. But in a milder infection, they're not going to overwhelm the hospitals anyways. It certainly can help if those children are interacting with our citizens that are more at risk, the elderly, their grandparents, people with significant medical conditions. Okay, that's fair. But let's be honest about that and not lump them in with everybody else and say, hey, wait a minute, everybody should get these vaccines and everybody should get a booster, right? When you're looking at the reactions, you can see that some of them were more severe than others, and meant that we had to really attend to these folks. Not that they shouldn't get primary series, not that they maybe shouldn't get a booster, but you really have to talk about that long and hard to make sure that you know that you're weighing that data back and forth to have a good clarity on how you look at that data. Okay, now, next, the variants. Okay, so this is the classic one that everybody's seen before, the alpha, beta, gamma, delta. There's been mu. Obviously, we're talking about Omicron. And in the original look at the Omicron, when it's first coming out, low levels. And by the way, this has gone all over the place about, you know, how much Omicron is there, but in general, it's clearly dominating the US now. How much does it dominate? Well, that's a very good question, because it's very hard to get good data on this. But that has grown to really displace any of the more worrisome things, right? And if you give an mRNA vaccine to the population, you're going to see these kinds of graphs. I know these are a little hard to see, but what they're talking about is that over time, if somebody takes a placebo, which are the blue lines, versus somebody takes the mRNA vaccines, they have very low levels of risk, right? They get very good benefit. Similarly, I know it's getting a little busy, but stay with me, please, please, please. Look at the different variants: alpha, beta, gamma, delta, epsilon, lambda, mu, right? This study was done before they had time to fully look at the Omicron, right? But nonetheless, it gives you an idea of how much variation there is in these antibody neutralization studies and how good they are at going after it. But in general, it works against all the variants. So if you look at some of the typical vaccine variant studies, you're going to see data like this, right? Blue line goes up, placebo, people didn't get it. Red line, the one that got it, big difference in the incidence of infection. So very efficacious, 97%, amazing, right? Why are there some differences, right? Well, one reason is because when you took the vaccine, they make a big difference. It turned out that if you had intervals between the primary series, your first and second shot of the mRNAs, and you increase those intervals, you probably got more protection. So that's why in some places you see different data sets. We're going to be talking a lot about Israel, because Israel's been at the forefront of a lot of this stuff, but I want to explain why some things can be different there. But you see these huge efficacy. So you're going to say to me, well, so why are there boosters if they work so well, right? Because if these have such long efficacy, why are there boosters, right? Well, first of all, let me tell you about the benefits of real illness. Here's a group of people. Now look, this is very important, very important. From New England Journal, one of our top journals, right? They looked at people who never had vaccine. They looked at people who had an infection and then got reinfected. And they had some people had severe disease, 4 out of 1,300, nobody critical, nobody died. This is the benefits of a real infection, right? Now, I'm not saying it's not an easy walk, right? Because look. In some of these primary infections, there was trouble, right? But that's also with different variants. When you start talking about the milder variants, then this data about worrisome primary infection doesn't hold up. And indeed, that's exactly what we're seeing right now with the current variant. So keep that in mind, because we know that the real illness will protect you and probably equal, if not better than the vaccine, okay? Israel. So Israel came out and said, well, hey, wait, we're seeing some data that we're having drop-offs in antibody levels, and we're worried about the breakthrough infection rates, right? And when you looked at some of the data, similar to the Mayo Clinic here, they started to show that Moderna was 76% effective, Pfizer 42%, right? They're saying, wait, hold on. But remember, I already told you that you just have to have 3% of those antibody levels, and you're going to be protected against the more severe stuff. 2, these were done with the Delta variant, right? Not with Omicron, and not with Mu, and not with the other ones that'll be coming. So every time that you hear about these drop-offs, you have to understand, yes, I've already told you there's drop-offs. Yes, there are some people that would benefit from booster if they're particularly vulnerable, right? But for the vast majority of people, that's probably not necessary. Furthermore, when you're talking about it, you have to know what variant you're up against and who's the patient, right? So there are going to always be breakthrough cases. Get ready for it. It's always going to happen. It doesn't matter if you have the real infection. It doesn't matter if you have the vaccines. It doesn't matter if you boost yourself forever. There's going to be some breakthrough infections. But with the real infection, you're going to be more likely to have a benefit that's going to be more robust, that's going to be more likely to help you with that, right? And so that's why you have to know what the trade-offs are. So the vaccines, they work. They work on the variants. And if they're 90% effective on a population basis, you want to get to at least 50% of your population to start protecting people. And the studies have shown that those with natural immunity do have equal, if not higher, protection than those who have never been infected in a natural infection at 6 months. There's little change, and you have more diverse antibodies. Add in a vaccine, and you are heavily protected against almost all disease, right? So full vaccination provides additional protection, which is why I told everybody who said, well, Mark, I got the thing. I still want you to get the primary series, right? I'm a big vaccine person. Everybody knows I'm a big vaccine person. I always want people, I'm always, when everybody's coming in for their checkups, I'm always saying, did you have this? Did you have this? I'm always on it, right? So no question, that's what I want, the primary series. No question, if you have the natural infection, I do want you to have had the primary series also. Most people have, okay? We see that the Chinese stuff is less effective. By the way, full disclosure, I was wrong on one thing previously, where I said that originally I was holding off my young ladies from getting a vaccination. Then I said, you know, look, for those that are ready to step in the pool, I'd probably do the J&J because it was based on old technology and it was only one shot. And it turns out that probably the mRNAs for young women are a little bit safer. So that's a little change there, right? If you wait longer between shots, that may help. So I've already told you that. So this is the primary series. If you haven't had your primary shots and you say, well, they say, well, do it now and do it again. You know what? If you do one now and you wait 4 weeks or 5 weeks, you're probably even a little bit better off, right? It is normal for antibodies to wait. I've told you that. And if they didn't, our bodies would be filled with antibodies. We wouldn't even have ability to function with blood cells, right? Which is why the T cells become so important. We know that the cold storage has been modified, so it's easy to get this around. And if you've had the infection, you say, okay, I had the infection, I didn't take the vaccine, do you still want me to take it? The answer I have is yes, right? And how long do you have to wait? A period of time, right? And it still shows data that'll be helpful for you. If you do go through and have an infection, haven't had the primary series, I want you to take it, right? The positives, with kids, there's less infection severity, there's less transmission, and you're more likely to ensure education continuity, okay? But remember, less kids were studied, right? And again, as I showed you in that 5 to 11-year-old group, right? I have my issues, right? Do I think that they should get it? Yeah. Do I think it's critical? No. Do I think they should get it based on a population basis, protect an elderly person? Yes. Do I think that on their own individual basis, that it makes a big difference for them to protect them? Probably not, probably limited. Again, you're talking small numbers either way, right? So you're more likely to have a negative infection from the vaccination. Just the way it is, right? You get these myocarditis, and you have to remember kids get this very lightly, right? Either way, the risks are low. So again, that's an open issue that everybody has to sort through, okay? So in kids, things have changed. 50 years ago, what's the meaning of these marks? Now, what's the meaning of these marks? You can see how these things change over time. Lots of things change for kids, and that's just the way it is. Okay. I want you to keep in mind some things about when you start hearing about deaths, okay? This is very important. First of all, overall, the data seems to suggest that over 99% of all the deaths are in unvaccinated or not fully vaccinated. So you have to keep that in mind. When you start hearing the reports, oh, the cases are up, the counts are up, the United States tested 1 million people are positive. Okay, there's a lot of issues here that you have to keep in mind, right? One is what's called the Pulseman Effect, which is people will change their behavior after a shot. So sometimes people get a shot, say, oh, good, I'm good. And now I'm going to go party it up and have a good time and stuff. So some of those people are going to get sick. That's just the way it is, whereas previously they didn't. So that's going to make your numbers look like there's a rise, okay? And vaccines can help both in the household and with friends, right? Now, Israel. So Israel did the mRNA Pfizer, a couple issues they had. First of all, they did show in the primary series these risks of the myocarditis, the inflamed heart, the Guillain-Barré, and there were breakthrough infections in healthcare workers, okay? No question about it, right? Couple issues. Israel did their vaccination very efficiently and early. They spaced them closer together than average, about 3 weeks. So that makes a difference on how much breakthrough you're going to see and how much you're going to expect from that immunization series, right? They also, what they defined as a severe level was a little bit looser than we might define it, but nonetheless, it's true. And then one other thing, this is a little technical, but I just, full disclosure, I just want to give it to you and then you can forget I told you this, because a lot of doctors don't even know this stuff. But when you say, I got a PCR test, the PCR test is not a black and white yes and no. The PCR test is based on threshold cycle counts. That's what that CT is. And the only reason I'm telling you this is to understand that you can have a PCR test that's positive, but it's weakly positive. And if it's weakly positive, you start having greater risk that it's a false positive. So when they start having these kinds of tests that say PCR positive, you have to know that I'm always looking at that interpretation to know what does it mean for that individual and certainly for that society. And that was one of the issues also in the Israel data, right? Now, third dose in Israel, okay? The third dose looks at the groups, look at the people, and no surprise, you get higher antibody levels. There's no question about that. There's no question the antibody levels go up, right? That's not my issue. My issue is that if you give a booster and the third and the antibodies, what does it mean? Is it really going to protect that individual? Is it worth the risk of the vaccine? Well, if somebody's 80, which is the median age for severe troubles, okay, that's a different story. If somebody's very obese, if somebody has an active cancer that they're under treatment, different story. I get it. But if we're talking about somebody in their teens, 20s, 30s, 40s, right? All of a sudden, I showed you the data that this is not the group that has a lot of trouble with these infections, and this is the group that has trouble with the vaccine response, right? So in the Israel booster study, they'll say, oh, there's a 10-fold reduction. Wow, that's big, right? You started in their studies from 5 million people, and when you start looking at the groups, you're down to 3 to 20,000 people. What does that mean? That means that the confidence intervals are high, which means statistically that when you have so few numbers based on a large data set, that the chance that these numbers could be wrong or misleading get higher. And next, Israel's a limited population ethnically. They didn't study all the health behaviors. They only follow these people for 54 days. And I'm going to show you why that becomes important, right? And when they say, well, they're 10-fold better, of course they're 10-fold better, but it goes from 90% effective to 99% effective. Well, if you're already 90% effective, you've already wiped out virtually anything of the severe stuff anyways, right? Further, in their study said COPD, which is lung disease, diabetes, heart disease, didn't make any difference. Well, wait. I showed you the data before that said that those things are associated with trouble. So why in Israel were these things not associated? So you can see why the data is not as clean as it may seem. Further, they were studying Delta. I'm not questioning. Delta was a more severe variant, but they weren't studying Omicron. Further, Delta. Do you remember everybody talking Delta, Delta, Delta? Where did it get started in India, right? But it went away. And India has 1 billion people. They never got anywhere close to immunizing all their population. So how's that possible? It's possible because this is the natural history of these infections, which is why if you only follow people for 54 days, you could be getting false numbers, right? Next, let's take a look at this. You look at this and say, okay, Mark, I've seen this before. You give the shot, people do better. You don't give the shot, they do worse, right? That's what you look at. But look at this. Look at their data. So this is very critical. Look at the age groups. These are the people that account for all that benefit. The 60s, 70s, and 80s. You take out this group, and the booster doesn't seem to make any difference, which is why I'm more equivocal on these younger groups about getting a booster. Again, if somebody's in their 60s, you know, okay, I could see it. I could see that it's probably worth the risk, maybe. 70s, I'm getting a little more convinced. 80s, okay, you should take it. But in these younger groups, I don't see the data suggesting this. I know this is complicated, but you have to understand it's not as black and white as it's portrayed, right? Why do you think that the own panel of the FDA, 16-2 said, don't give boosters to people under 65, yet they still said you got to do it? Why is that? Right? This is why data needs to be looked at carefully, okay? And here's the data where I said to you that they did not see some of these same risk groups that we normally see in our studies as being important. Again, questioning how reliable is that Israel data? How applicable is it to you, right? All right. Based on blood donations, by the middle of last year, we had about 83% of the US donors showed some coronavirus antibodies, which means that we're getting immunized as a population over time. Vaccine may help prevent some long COVID, which is why, like primary series, again, boosters, I feel differently. The UK dosing suggests wider intervals may be more helpful, right? Now, I want to show you something else about boosters, okay? Look at this very carefully. This is a study from Denmark, okay? This is very important. Look at this study. You look at this and say, oh, I see vaccine effectiveness. Look how effective it is over here. Look how effective it is. Wait. What's exactly going on here with these green lines? Why are they crossing over no effectiveness? And why, when you get to 90 to 150 days, if anything, the vaccines look like they're permissive, meaning all of a sudden those people that got the boosters, they're doing worse later. But I told you Israel only followed for 54 days. So you just do this part of the curve and you're going to see one answer, right? And this is with Omicron, right? Which is the one we're dealing with right now. This is why it's so important to keep that booster information in mind. Because in this study, if anything, not only was it not of benefit in the long run, it might have been harmful. Well, you say, well, how's that possible? Well, remember, I told you before, when you have these antibodies that attack the virus, sometimes you will get antibodies that can make it more permissive, right? This is the way it goes. With the variants, there will always be what's called antigenic shift and antigenic drift. There will be variants in every condition. These are always endemic. We're now measuring variants where we didn't used to, right? In the flu, we didn't used to take a careful look at these. In the flu, you had that. By the way, I want you to remember something. A couple things. One. Influenza mutates at twice the rate of coronavirus, right? And so that's why we give flu shots every year. And by the way, if you haven't had flu shot this year, I want you to get your flu shot. You know, I'm a big vaccine person. I want that, right? I'm only pointing out some of the trade-offs that need to be kept in mind, okay? These things are endemic. Remember, I told you that before, and that's important to always keep in mind, okay? Next, COVID variants are more transmissible and all contain adaptations in that spike protein. It's a normal process, and when things change in selection pressures, these will change. What is important is to keep in mind that in medicine, you identify the risk groups and you focus on them, right? That's why I showed you those graphs, whereas looking at those studies where who was really benefiting, who was really at risk, especially from those boosters, it's those risk groups, right? And so that's something to keep in mind as to how these things will get impacted, how they get affected, right? There's a term, cervical virus, which is a virus of potential cause, and they already are studying those. And the current vaccines appear to be able to cover them, right? Remember, it is in the virus' best interest not to be lethal, right? So when I first gave my talks, you may recall I said to you, there's going to be variants. I said to you that there's going to be mutations. And I said to you, and not all that's bad news, because the viruses have an adaptation where they don't want to be lethal. Because if they're lethal, then they kill off all their hosts and they can't replicate. That's why, by the way, that's why when the original SARS and the original MERS came out, those were not pandemics. They were localized epidemics because they're very lethal. So they killed off all the hosts very quickly. It didn't get to transmit. But over time, if you start having these types of variants, which is what is going to happen, they're not going to be bad. And if anything, I'm not wishing illness on anyone, but if somebody were to say to me, what's the best vaccine right now? The best vaccine right now is Omicron. Because if you get a natural infection, I showed you all the data about the benefits of natural infection. I showed you all the data about not getting side effects from these vaccines, right? And again, I'm not talking about the primary series. I want everybody to get the primary series. I'm talking about what to do in interpretation, especially with boosters, right? About keeping in mind what's going on and what we're up against, okay? Public health response, again, there's no good data about these lockdowns, and there is good data that the lockdowns have created more harm and killed more people and was not a good issue to pursue. Australia is up there, their head in trouble. Everybody always tell me, oh, Australia did this. Look, Australia's having lots of trouble right now, okay? And so what about people say, what about the public health of wearing masks? Okay, there's a lot of stuff back and forth. I don't have time to do the whole mask talk. You may have heard it from me before, but in general, if you're indoors in a small room with a lot of people who you don't know and you want to wear a mask, okay, you know, it's fine. Otherwise, this nonsense about walking outside and being outside with masks on is crazy. It's just crazy. It's just not even tethered to medical reality, and should not be something that's even suggested by anyone, right? When you look at some of the data in the literature, if you want to look it up, Ladapo, who's now head of Florida's program, talked about this. And remember, he talked about the cases being driven by asymptomatic spread. That's just the way it is, folks. It's not going to be who got sick and when it's going to be people that before they're sick. It's going to be kids that were not sick that you didn't know. It's going to be people that are just born with good immune systems. People already have antibodies. They're just not going to be the ones that are going to cause you to be aware of what's going on, right? And so that's one of the things that's important to keep in mind for that. Okay. Next, there's good data though on the negative impacts when kids are not in school, right? So that's part of that ebb and flow we talked about whether or not to immunize the kids and what does that mean for the kids. Next, I have to spend time in this. This is something, if you forget everything else that I've tried to impart, which of course would bother me because I've tried to do it well, but you have to know that the data reporting is so misleading because everybody's saying cases are up, the hospitals are up, and all this kind of stuff. First of all, everybody's entering a hospital is getting tested for corona. everybody. 2, we didn't used to do that before with flu and a lot of other things. 3, when they get tested, if they're positive, it's not that they have infection. It's not that they're in the hospital with corona. It's not that they're even sick with corona. It could be that there's some viral particles left over from a past infection. But it gets reported as a corona case, and the hospitals get paid more for doing that. They say, oh, we got another corona case. Good for us. We're going to make more money. That's why all this data is so distorted about what is or is not a corona case, okay? So this is the terrible COVID cycle that we're all in. You stay at home, you get a new vaccine's created, you get the vaccine, then you put the man's back, and it goes around and around in a circle, and it drives everybody nuts, okay? So some final points. The third booster shot. Probably in the future with a different formulation, I would be much more supportive of it, right? I support this in immunocompromised. And remember, we're only measuring the antibody levels, not the whole cellular system. And I've gone through, again, all the data with you about the importance of T cells. You raise the antibody levels, and you probably increase the proportion of people who respond. But again, I've gone through with you that it doesn't have clarity that those higher levels is going to make a big difference for you, right? Next, the reactogenicity of third dose seems to be similar to the others. And again, I've told you why I have grave difficulties about this stuff in the kids, the adolescents, and the teens, the 20s, the 30s, because remember, I showed you the data. The problems are in the older folks, 60s, 70s, 80s. It's the people that have the problems where a booster can be justified to balance against the risk, because these boosters have risk, right? The CD recommends for general public. I've talked about that. But we've talked about the side effects, and it's questionable effect. And I'm not just the only one. The whole Barrington Declaration group is against this. That's 17,000 care providers, by the way. The FDA panel, 16-2, was against this, right? As of December, we've had about 5 billion doses worldwide. U.S. is 486 million. 202 million people are fully vaccinated. The warp speed, I talked about that before, was good. There's still the good safety monitoring. Anaphylaxis is rare. The safety is consistent with the trials, but there is safety issues, right? And that's what I've tried to highlight with you. Okay, and that's the end of this talk. And what I'm going to do now is go